Holmium laser enucleation of the prostate (HoLEP) is among the most extensively studied laser techniques for the treatment of benign prostatic hyperplasia. Our objective is to present a video demonstrating a one-lobe enucleation technique. The most important aspect of this technique is that there is no incision at the 5 o'clock or 7 o'clock positions. The median lobe and bilateral lobes are enucleated en bloc. The operative procedure is the same, regardless of the presence or absence of the middle lobe. It is a simple procedure. There is less blood loss than with other techniques, because the adenoma is not incised, making it a safe and rapid method. 1. The mucosa is incised bilaterally between the lateral lobe and the viriomontanum. 2. The urethral mucosa at the bladder neck is vaporized to the surgical capsule at the 12 o'clock position. 3. The mucosa of the right and left lobes is incised from the bladder neck to the apex. 4. The lateral lobe is dissected from the surgical capsule. 5. The mucosal strip is transected at the apex. 6. Dissection is performed from the lateral lobe to the bladder neck at the 6 o'clock position. The initial incision is made at either the 5 o'clock or 7 o'clock position, in the groove between the median and lateral lobes, taking care not to damage the smooth muscle sphincter near the viriomontanum. The urethral mucosa at the bladder neck is vaporized to the surgical capsule at the 12 o'clock position. The endoscope is turned 180 so that the sphincter muscle at the 12 o'clock position can be clearly seen. The urethral mucosa at the 12 o'clock position is vaporized to the surgical capsule. The procedure of it is to make the endpoint at the bladder neck. The landmark at the bladder neck is the annular capsular fibers. The right urethral mucosa is dissected from the bladder neck to the apex. This incision should be made to avoid sphincter damage, which leads to stress urinary incontinence. The other side is dissected in the same way. The lateral lobe is dissected from the surgical capsule. Next, the lateral lobe is dissected from the surgical capsule at the middle of the adenoma. The layers separating the adenoma from the capsule can be found easily. The other side is dissected in the same way. The mucosal strip is shown here. The mucosal strip is transected at the apex. The laser fiber is moved in a smooth horizontal motion from apex to bladder neck. Dissection is performed from the lateral lobe to the bladder neck at the 6 o'clock position. The lateral lobe is enucleated from the surgical capsule of the lateral wall to the floor of the fossa circumferentially. The procedure of it is carried out as peel-off without cutting. There is a low risk of penetrating the dorsal aspect of the bladder with this method. Regardless of the presence or absence of the middle lobe, it can be enucleated en bloc. Finally, the remaining attachment between the adenoma and the surgical capsule at the 6 o'clock position is dissected from the left and right sides. The adenoma is enucleated en bloc. It is now shown floating within the bladder. This graph shows the number of surgeries performed at our institution. Since May 2009, approximately 600 procedures have been performed. The different colors in the graph indicate the particular operative method used. The blue bar, for instance, represents the 3-lobe technique, which was the original method reported by Gieling and Lingerman. We began performing a one-lobe enucleation technique combined with retrograde and antegrade dissections. There were no significant differences in patient characteristics among the groups. The median prostate volume was approximately 60 milliliters, with a range from 17 to 300. There were also no significant intergroup differences with respect to the enucleation volume or decreased hemoglobin. However, the patients who underwent surgery more recently tended to have shorter enucleation times. One reason for shorter surgical times is the learning curve, but another reason may be the change in methods from a 3-lobe to a 1-lobe technique. Commonly observed postoperative complications are summarized in this slide. At initial postoperative evaluation, stress urinary incontinence, or SUI, was observed in 16.2% of patients after the 2-lobe technique, and in 6.2% after the 1-lobe technique. There were no significant intergroup differences in the incidence of SUI 3 months after surgery. There were no cases of bladder injury. Allogenic transfusion was required in 1 patient. The 1-lobe enucleation technique is simple, rapid, and safe. We will no longer perform the original 2 or 3-lobe surgical procedures.